I can also percuss down here, very light touch. Down here, if he had any pain, he would, with his kidneys, he would probably be jumping off the couch. But there's no signs of kidney problems, so I'm not too worried about that. Now what I'll do is I'll listen to his auscultate for his lung sounds. Take a deep breath for me. Very good. So his lungs sound clear, and there is an absence of rales, crackles, or advantageous sounds. So his lungs sound really good and clear. I heard more bronchovesicular sounds up here, and then as we got down, more vesicular sounds, but those are normal findings. So now that we've auscultated the back of my patient, I'll have him turn around and we can auscultate the front. So once again, I want to just observe my patient's breathing. He's breathing normal rate and rhythm. He's even and unlabored. Doesn't show any signs of cyanosis. So these are all good findings. Once again, I want to be checking his chest wall expansion. For the privacy of my patient, I'm not going to be asking him to take off his shirt, but I would do that. I would also assess for tactile firmitus, the same way that we did on the back, as he repeats 99.
99.
You don't have to, but that's what I would be doing all the way down. Then, once again, I would percuss for just areas of tenderness. Any areas of tenderness?
No.
No, so there's no areas of tenderness. Also, I would listen to his breath sounds. Take a deep breath for me. And it's difficult to hear over a shirt, so, but I can tell you from the back and also from the front, my patient has good, clear, bilateral breath sounds. No advantageous sounds are heard. Once again, with this, you should hear bronchovesicular sounds up here, and then as you move down, more vesicular sounds can be heard, so those are normal findings. If I was to listen to the trachea, which I already did, but you'll hear more high-pitched sounds there. All right, so moving on from the respiratory system, I'd like to now focus in on my heart sound. So if you could, I'd like you to go ahead and lie down at a 30-degree angle like I had you lie down before. So when you assess the heart, it is always best to assess the patient lying down at a 30 to 40-degree angle, sitting up, or lying on their left side. Today, my patient, I'm going to be assessing him just on his back at a 30-degree angle. So I like to get close to my patient, and the way I do this is I like to observe first. So right now, I'm just observing his chest. I'm not going to notice, I'm looking to see if I notice heart rising out of the chest. It's usually you don't find that. It can be normal for some people if they're really thin, but normally you don't see that, and I'm unable to see that at this time. I'd also be assessing, and I'm sorry I forgot to mention this, but when I was looking at the back, I also looked at the skin condition, which was evenly toned, no discolorations, some acne, but not a lot, and it was of even thickness everywhere. And I would be doing that here as well with the chest. So there's a birthmark here, there is some chest hair, evenly distributed, kind of patchy, but normal for chest hair. And yes, so then I'd move on and I would palpate the chest, where the chest would be, where the heart would be, excuse me. And I'd also try and find the pulse with my fingertips. I'm going to do that. Good. So I found the pulse with my fingertips. It's just a small, it should be a small area where it can be felt. It's a light palpation. I'd still say it's about a +2. And then once I've done that, once I've palpated, I will also auscultate the heart. I'll be listening to all areas surrounding the heart. I'm first listening with the with the diaphragm of the stethoscope. I'm listening for S1 and S2 sounds. I was able to hear an S1 and S2. S1 is easier to be heard at the apex of the heart, and S2 is easier to be heard at the base of the heart. I did find both of those sounds. I did not hear S3 or S4, which is a normal finding, and I did not hear any gallops or murmurs. However, because I only listen with the diaphragm, I'm also going to turn it over and listen with the bell. Good. S1 and S2 are heard well. It's a good lub-dub sound. No abnormal sounds or abnormal findings with the heart. And so now I'm going to move on to the abdominal portion, since my patient's already laying down. So with the abdominal portion, what I would like to do is just first assess the contour of my patient's abdominal region. So it's nice and flat, has a roundish curve to it, which are normal. The belly is not distended. Right. So then from there, I'm always going to, and it's a normal color, there's no discolorations noted. So I'm going to always listen first. The reason you listen first is because if you were to palpate or to percuss the stomach before listening to it, you could cause peristalsis, and but it wouldn't be real. So you want to make sure that you auscultate first. I always start with the right lower quadrant and work my way around, because the ileocecal valve is there, and you can best hear bowel sounds in that area. Good. 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 So my patient has normal bowel sounds. I'd also ask my patient when the last time he had a bowel movement was, or also when the last time he ate anything was, because that could also help determine, the bowel sounds that you're hearing. It's always important to listen to the vowel sounds for as long as you can to distinguish whether or not they are normal, they're hyper, hypo, or absent. If they are absent, it is important that you listen to the vowel sounds for at least 5 minutes. The umbilicus is inverted and it is midline, which is a good normal finding. There is some hair there, but that's also normal in males. Once I've done that, I can lightly palpate and percuss. So I'll start with, when I palpate, I'm just lightly palpating. If he had an area of the stomach or the abdomen that he was painful, I'd be checking his his facial movements to see if there was any guarding or pain that he was having. Also, I want to, whatever area that he told me was in pain, I'd want to save that for last. Any tenderness? No? Okay. I can palpate the liver here, which is pretty much right underneath the ribs. Take a deep breath for me. Okay. And I'm able to feel it. Okay. I shouldn't be able to feel the gallbladder. If I do feel a gallbladder underneath the liver, then it could be a sign of an enlarged gallbladder, which could have some gallbladder disease. On the right side of my patient's body, I can have him take a deep breath again. Underneath there and see if I can feel the spleen, which I cannot. Kidneys can sometimes be felt, and they're little round areas, but I'm unable to take a deep breath. I'm unable to feel the kidneys. They're not able to be felt on everyone. Once I finish palpating, I can palpate the bladder area, which is also sometimes felt by pressing an upward movement. Okay. And then also I can percuss. So the way I would percuss is, there are going to be areas of dullness, and there will also be areas of tympanic sounds. Areas of dullness are normal over solid organs, and then areas of tympanic sounds are normal over air-filled organs. So over the liver, it should be dull. Over the stomach, nice resonant sounds, tympanic sounds. And I could continue to go further down to the femoral region, but I'm not going to do this on this patient today. Also, something that I forgot to mention, but that's something that I would do, I've already done percussion and already done palpation, but another thing that I could have listened for were bruits to be heard in either the aorta, the renal arteries, the iliac region, and also the femoral arteries. I would listen with the bell of my stethoscope to see if I heard any bruits there. My patient is normal. I've had all normal findings right now, so it's not necessarily imperative that I do that, but if my patient was having any heart issues, it would definitely, or abdominal problems, it would definitely be wise to listen to those areas. Okay. So moving on from the abdomen, you can go ahead and have sit back up. So now what I want to do is I want to assess the upper extremities. When I'm looking at the upper extremities, I'm looking for a few things. I'm looking for range of motion. I'm looking for strength or muscle mass. And I'm also looking for the skin texture. So I'm looking at the patient's arms. And the temperature, which is warm in the hands, warm all the way up. So even skin temperature, which is a good finding, should be warm. The skin is nice and soft. It's even thickness, even toned. There is some hair here, but it's evenly distributed, normal in the areas that it should be, more abundant in the forearms, less abundant in the upper arms. Cap refill. Turn your hands over for me. Cap refill is less than 2 seconds, which is a normal finding. There is no edema present in the arms.